Welcome to the Menopause and Cancer podcast, where we speak with cancer patients, survivors, and menopause experts to help us find solutions to our symptoms and ideas to improve our health. My name is Danny Binnington, and today we're going to be exploring why a cancer patient who is also a gynecologist and a menopause expert would consider hormone replacement therapy after her own breast cancer diagnosis. I know this is an emotive subject that is very controversial, but I'm feeling it's really important to have this conversation. I'm delighted to welcome the brilliantly wonderful and gorgeous Dr. Corinne Menn onto the podcast today, a US board-certified gynecologist who will share her own story of why she decided to go on hormone replacement therapy many years after her breast cancer diagnosis. Welcome to the podcast. How are you today?
I'm so great. Thank you so much for having me.
We're going to go straight into the deep end. You're a gynecologist, menopause specialist, a breast cancer survivor yourself. Many years after your diagnosis, you started to take hormone replacement therapy. This is a controversial episode. I've already got goosebumps, but I want to have this conversation with you in a non-judgmental way and really hear from you as the patient and you as the expert. Where do we start?
Well, we can start just with my kind of story of my diagnosis, so we all kind of know where I'm coming from, because remember, for all the listeners out there, it's just always important that they understand that every breast cancer is like your unique fingerprint. It's very hard to kind of compare, all our individual cases, because, breast cancer is an incredibly complex and very individualized cancer. But that's why we need to start to individualize how we care for these women. And that's not being done. So my unique story is that when I was 28, I was a second year OBGYN resident in New York, and no family history of breast cancer or any cancers. And my mom is diagnosed with stage 4 ovarian cancer, and she dies a few months later. Around the time of her diagnosis, I felt a small lump in my breast. All my fellow OBGYN residents, they were all female, they all felt it. And they're like, oh, Corinne, it's just a fibroadenoma. I put it off. Everyone's like, oh, it's just a cyst or fibroadenoma. Don't worry. So there was the first time that I was doing wrong by myself, right? Because I didn't listen to my body. I was really too busy taking care of other women and then dealing with my mom. She dies in November of 2001. And I was like, damn, I should probably get this checked out. Like, that's a little weird. She was only 54. Lo and behold, finally, right before the Christmas holidays in 2001, I was diagnosed with stage 2 estrogen receptor positive, progesterone receptor positive, HER2 negative breast cancer. I had a bilateral mastectomy, and I had my one sentinel node had a micrometastatic focus. So it was less than 2 millimeter, which made me at the time 2A. I believe they now make that a 1B. But so I was a stage 2A breast cancer. My tumor was at 1.4 centimeters, and then I did. I did save some eggs prior to chemotherapy, wound up not needing that. We'll talk about that. But I had 4 cycles of adriamycin and Cytoxan, then 4 cycles of Taxotere. They gave me Lupron to shut down my ovaries during chemo, because at the time they thought that might help preserve ovarian function and reserve, which they were trying to do because I was young. And then as soon as I finished chemotherapy, they put me on Tamoxifen. And then we can talk separately about, lots happened after that as well. But that was my initial treatment. And it was, like a bat out of hell, right? Like, you're 28, newly married, thinking about maybe starting a family soon. I'm spending my days delivering babies on the labor and delivery floor, and on the gynecology floor, I was taking care of sick ovarian cancer patients, uterine cancer, very complicated. So it was a very jarring and very kind of traumatic environment for me to be in. No one understood young women. I felt like an oddity when I was getting my chemotherapy. Everyone looked at me like, oh, she's so young for breast cancer. So it was traumatic on so many levels. And my own fellow OBGYNs had never heard of such a young person with breast cancer, even though it's actually the most common cancer in young women, right? And certainly nobody knew what to do with all of my side effects that then happened from my chemotherapy and my early menopause.
Yeah. And I can hear you want to fill us in on your story, but if I just try and imagine this young woman who's not only struggling because she's losing her mother to a cancer that you also treat other cancer patients for. And then you're also diagnosed with a cancer of the female organs or body parts. This is huge. This shakes the foundations of femininity, right? Of breast cancer treatment, changes our body, but also our sort of internal puzzle is kind of like exploded, and then we're put together, but often in the wrong way. That's how I felt for a long time. Like my puzzle pieces don't fit anymore. And some of them were taken away with trauma forever, and others replaced, and they got changed. And you end up this new person trying to figure out who you are. I suppose as a young patient who was also busy being a young expert, you took the treatment, like we embark on surgery and chemotherapy and tamoxifen, because this is what's recommended to us. And we want to do everything in our most possible way to survive. Did you feel like that as well? Hey, thanks for watching this episode. 73% of people who watch my podcast haven't yet clicked the subscribe button, and 11% haven't hit the button to turn on notifications. I want these conversations to reach as many women as possible who might need to hear them. So if you've ever enjoyed listening to this podcast, please hit subscribe now.
Yes. And, granted, I was in a privileged position in that I was a physician. I was in New York City. I had access to doctor friends who got me into the best experts in the world. And I will have to say, looking back, I felt lucky that I felt very, I knew what my treatment options were: mastectomy, lumpectomy, the different chemotherapy. I understood tamoxifen. They weren't really using aromatase inhibitors that much at the time. I'm sure they would have put me on it if it was now. I did get good care initially. I think the biggest problem is that once they treated me for my primary breast cancer with, I completed my chemotherapy, and I was lucky enough at the time to work with someone in New York City who was kind of on the cutting edge of fertility preservation for breast cancer survivors. And so before chemo, I did save ovaries. And for your listeners, very interesting, they used tamoxifen to stimulate my ovaries to harvest eggs. And that's because tamoxifen is not an estrogen blocker. It's just not. In fact, when you take tamoxifen, your estrogen levels for a premenopausal woman, they rise. So you get an increase in estrogen levels, and it stimulated my ovaries to produce lots of eggs, and they were able to harvest a bunch of those eggs. And we froze them. I didn't need those eggs because down the road, once I came off the Lupron, my periods did come back. Because when you're younger and you go through chemotherapy, your periods often do come back. And so I was able, once my periods came back, I made the decision with my oncologist and my husband. We said, okay, we're going to try for a pregnancy. And I was able to immediately get pregnant on my own, had a healthy baby, and she's 19 now. And then when I finished, so I stopped my tamoxifen, got pregnant, had my baby, went back on my tamoxifen. Basically, that's the positive trial that was just presented at ASCO this past winter, which says that women in estrogen receptor positive breast cancer can pause their adjuvant endocrine therapy, come off it, have their estrogen levels rise, hopefully their periods come back, and they're able to pursue pregnancy with very high levels of estrogen in their pregnancy, and then they can go back on their adjuvant endocrine therapy. So I did that study basically myself. It was 20 years ago. So I was lucky to have forward-thinking physicians in terms of that. But it's very interesting for our conversation about menopause. Let's relate it back to the pregnancy thing. There is now, it should be common knowledge that women who are breast cancer survivors can still pursue a pregnancy. But let's keep the logical thinking going here, right? During that pregnancy, you have incredibly high levels of estrogen, right? And what the studies have shown is that you don't have an increased risk of recurrence or a worse prognosis if you pause your treatment so that you could get pregnant, or if you frankly get pregnant after you've totally completed your treatment. And the data was there 20 years ago, and that's why I felt comfortable doing it. And so we've got now 20 years more of that data, plus this incredible positive trial. So I think that's often something I bring up when I'm talking about hormone therapy in menopause, to kind of let's look at where hormones intersect with breast cancer patients in other scenarios. So that's an important little point.
How did you do on your tamoxifen? Because we have, women that are sent away by their oncologist saying, oh, just take this little white pill for the next 5 years.
Yeah.
Some women are sent away with a lot more information. We hear very mixed reports. Some oncologists say we didn't want to give too much information out because this woman might not have all of these bad symptoms. And so it's a really personal conversation to have with your medical professionals. Were you, as a medic yourself, did you know what you could expect, and how was your experience?
So my experience as a patient, I would say, my doctors were good. They were kind to me. They did the best I think that they thought they were doing. But no, nobody explained any of the side effects. No one ever talked about menopause. No one ever talked about the hormonal changes I was going to face from the Lupron injection. And they didn't explain the differences to me between tamoxifen used in premenopausal women versus tamoxifen in a postmenopausal women. They really have different side effects. It presents differently in those women. So no, I was not prepared whatsoever. And in retrospect, I think I often blamed things on, it's chemo brain.
Yeah.
From chemo, that's one thing. And my experience with tamoxifen was unique because I was on tamoxifen when I wasn't getting my period. So I was menopausal, right? Then my periods kind of came back on their own, right? They recovered. Then I had a baby, went back on the tamoxifen, and I did great on tamoxifen when I was still getting my period. And we know that we can give tamoxifen to premenopausal women for early stage breast cancer, right? As adjuvant therapy. We don't necessarily have to do hormone suppression, ovarian suppression, in addition to tamoxifen. Meaning those women who are taking tamoxifen, who are premenopausal without ovarian suppression, have very high levels of estrogen. So if you were taking tamoxifen and you were premenopausal, your side effects are probably going to be a lot different than if they give you tamoxifen and you're now either postmenopausal because you don't have ovaries anymore or you're on Lupron, right? When I was premenopausal hormonally and taking tamoxifen, I personally tolerated it really, really well. I honestly didn't have problems with it. I see patients all the time that within a week of taking tamoxifen, regardless of being pre or postmenopausal, they do have a lot of significant effects. But I wished my oncologist would have explained to me that tamoxifen does not do the following. It does not put you into menopause. It does not lower your estrogen levels, okay? It does not cause early menopause, right? If you're premenopausal and you're taking tamoxifen, you need to understand it's a designer estrogen is what they're giving you. It's a selective estrogen receptor modulator. We have to stop calling it a blocker, because when we call tamoxifen an estrogen blocker, it makes us feel very afraid of any estrogen and of something in our own bodies.
But does it block that the estrogen goes to your breasts? Is that where maybe that language is coming from? Or how does it work in the body?
I think listen, in medicine, doctors are busy. They're trying to see patients with complicated things. And it's just easy to use these euphemisms and these kind of it's an estrogen blocker. It's going to lower your risk of breast cancer. But it's very it doesn't really inform a patient. So it's very important for women to understand that there's receptors in your body to estrogen in all of your cells, and on your breast cells, if you have intact breasts, or if you have breast cells that are floating around, setting up shop, being quiet, they've escaped chemotherapy, and they're just kind of sitting there waiting. What the tamoxifen can do is bind to the estrogen receptor and kind of compete with estrogen from binding to the receptor. And basically, it's not allowing that receptor to be kind of stimulated to tell it to kind of work towards cell growth. But the thing about tamoxifen that people don't understand, and I think it would be very powerful for women to understand this, is that scientists know that tamoxifen works in probably 10 other ways besides the estrogen receptor. And in fact, at the Menopause Society conference, we were just at the National Society conference in the US, there was a lot of emphasis on these selective estrogen receptor modulators and how they actually function. And they really kind of celebrated how tamoxifen and these other SERMs work by, doing things on your immune system and stimulating different immune cells and and doing other things in the environment around a breast cancer cell that, really creates an anti-tumor effect. And so this is why tamoxifen does a beautiful job in women who still have very high levels of estrogen in premenopausal women. So I think that's another talking point. So I talk about the pregnancy, we talk about how tamoxifen works, and it starts making women understand like, oh, it's not estrogen bad, estrogen good, or, we have to cut off all sources of estrogen. It's a lot more nuanced, and that kind of will help us, get to the point where we can talk about hormone therapy after breast cancer.
Yeah. And I think when we talk about estrogens in general, we translate them into all areas of our life. I've just been on a workshop with an amazing oncology nutritionist, and we had 40 women joining us for the conversation. And 3 women always ask, do I need to stay away from phytoestrogens in my food? I had an estrogen-driven breast cancer. And so it's this, the conversation is the same, isn't it? Whether we are not so well informed on how tamoxifen works, or whether we don't really know what phytoestrogens can do for us. It's this real worry about the estrogens in general.
Yeah. Absolutely. And you just said something which I'm going to call you out on. You said something about estrogen-driven cancers. And I think so really, there's a couple of things when people say, yeah, I have that kind of cancer that is caused by estrogen, they say, or it's estrogen, or estrogen is fueling my cancer, or estrogen caused my cancer. And it's just completely wrong language. And it's really, it's a fundamental language difference that we need to change, because women really are not understanding even what their cancer was. So to be very clear, all breast cells in your body, that's not cancer, that's just a regular breast cell, has estrogen receptors, as does receptors on cells in your bone and in your skin, in your uterine lining, your ovaries, and your brain, okay? Estrogen receptors are on all tissue, right? So let's talk about the breast cell. A normal looking healthy breast cell is going to have estrogen and progesterone receptors. When we look at cancer, and when they look under the microscope and they're looking, how angry does the cancer cell in any cancer look? How different does it look from a normal cell? That's what the pathologist is looking at. So when we're looking at breast cancer cells, when we look down at the cell and we see that those cells have still retained their estrogen receptors, it means they actually still look fairly similar to a normal breast cell. When you were talking about estrogen receptor and progesterone receptor negative breast cancer, those breast cells have changed and become so angry looking, I like to say, that they've actually lost their receptors to estrogen and progesterone, okay?
So that was me.
Yes. And so in those patients, those cancer cells have changed in a way that there are no more receptors, right? And they often divide a little bit quicker and more rapidly. And they often, in general, respond a little bit more to chemotherapy, because chemotherapy works on rapidly dividing cells. Estrogen receptor positive breast cancer means that your breast cancer just happen to still retain its receptors. It does not mean estrogen caused your breast cancer. It doesn't mean it's an estrogen-driven breast cancer. It means that there's something on those breast cancer cells that we as doctors in science can use to manipulate that breast cancer cell temporarily to treat your breast cancer. Just like there's treatments that are being developed for estrogen receptor negative breast cancer patients, where they can manipulate and do different things to help, keep that cell from kind of growing and coming back, okay? And that's a very different concept than estrogen drives my breast cancer. And because receptors, it caused it. And when patients or hear it from their oncologist, well, you've got like the kind of cancers that's caused by estrogen, it makes women feel that their own bodies are their own hormones are killing them and hurting them. And it's just not true. And I think it's very important, because then it sets up fear for things like vaginal estrogen, or reasonable conversation about a well-treated patient who's completed her therapy and is really suffering from the menopausal symptoms. And, it leads her to have just an utter misunderstanding and fear from the get-go of even discussing low-dose hormone therapy.
And really coming back to sort of the risks of breast cancer, it's bad luck, right? We know that. It's being a woman, it's having breasts, and those are unmodifiable risk factors. And I think that is the hardest when it comes to being diagnosed with cancer, any type of cancer, because a lot of the risks we can't mitigate. We can't take them away, however much we're trying to. Tell me what happened next in your story. You had your baby, you had your daughter, you went back on the tamoxifen. Second time round, from what I heard from you, wasn't so easy. How old were you then? And then when did you stop tamoxifen? What happened next?
After delivering Eva, I went right back on tamoxifen. Initially, I let them do 6 months of Lupron. They're like, oh, let's just, and again, this is them just playing around and not having any science here about this. Well, let's just suppress your ovarian function. I was like, okay. I felt so grateful that they let me, quote unquote, get pregnant. And I was like, okay. And so then immediately deliver a baby, they put me into artificial menopause again with the Lupron shot. So I did not tolerate that well. And I said, no, thank you to the Lupron anymore. Let me just stay on tamoxifen. And at that time, I was about 31 then. And at this point, speaking of risk factors, this is a perfect segue. At this point, I had tested negative for the BRCA1 and 2 gene. And remember, my mom dies at 54 of ovarian cancer. I'm 28 with breast cancer. It never sat right with me. It seemed, well, obviously there's something wrong with my genes because that just is too weird, right? And they're like, yeah, you're negative. Fine. Around that time, I was, making the decision and like, okay, I'm going to stay on this tamoxifen. I'm going to complete it for my 5 years at least. And around that time, a dear friend who I met during my breast cancer journey, she unfortunately passed away from breast cancer right after delivering her baby. Her metastatic disease was there before she was probably pregnant. She was it was a very tragic situation. And in that moment, I made this kind of decision like, okay, I just want to stay on my tamoxifen. And we decided to adopt our second child. And we did that. Little baby girl from, we traveled to Guatemala and she's now 17. But so
Wow.
I've got my family complete. I've got my 2 daughters. And at that point, I'm on my tamoxifen, kind of handling it okay, because at this point, I wasn't menopausal, right? And
Corinne, I'm going to stop you. At that point, because at every single point in our journey, we weigh up our risks versus benefits. Should I eat the apple, the sugary, I don't know, chocolate, whatever it is? It's a whole life is risks versus benefits conversation, isn't it? At the point where you wanted to complete your family with a second child, did it feel too risky for you to stop your tamoxifen because of what happened to your friend? You didn't want
yeah.
to stop tamoxifen.
So in retrospect, I think I made a very emotional decision. And it was, I was living in a gray zone, right? It's 28, premenopausal breast cancer, very young, already had 1 pregnancy, an emotional reaction to seeing a friend pass away. Again, her cancer, never mind. So there was no science that says what's the next best thing. But yes, I made my decision out of fear of, obviously wanting to survive and be there for my baby. And also just saying like, okay, they told me 5 to 10 years of tamoxifen. Let me try to get that. How can I do that without taking another pause, right?
I get it.
In retrospect now, I probably could have had a second pregnancy and then just continued on with my tamoxifen. But at the time, that felt right to me. And the other thing that felt right to me, once we adopted Lucia, we decided that like, okay, mom died of ovarian cancer. I know I tested negative for this gene. Something doesn't feel right. I want my ovaries out. Okay. Again, this was me listening to my inner soul, and my doctors were like, you don't have to. You don't carry the gene. I said, I know, but something doesn't make sense, people. And now this was another big turning point where now I chose to have an elective oophorectomy, and I was not prepared for what came next, the surgical menopause. And I think it was a fear. It was definitely a little bit of a fear-based decision, but there was something in me that was telling me I should do that. So I do that, and within 2 months, my life had really changed. Lupron was difficult, but it was temporary. Being surgically menopausal plus the tamoxifen, but it was really the surgical menopause me over the edge. Probably gained 15 pounds in 2 months, horrible joint pain. My insomnia was through the roof, the sexual side effects, the mood changes, you talk about it all the time. That was severe. And that's when I got involved with the North American Menopause Society, now called the Menopause Society, and said, Lord, I've got to learn how to deal with menopausal women, because if this is what they're dealing with, God, I feel so bad for them, because I was at this point in my early 30s. Like, I had no reason to sympathize with menopausal women except for my own personal experience. But at that time I was like, well, I can help them. I can't help myself, because God, I can't have anything, hormone related. And at that point, looking back, nobody, not my oncologist, my GYN, nobody at any point in time, and at that point it had been probably 7 years from my original diagnosis, had ever said, hey, Corinne, you are not sleeping well. What does that do to your mood? Corinne, what about the sexual side effects? Are you having painful sex? How are your bones? How is your brain health? Nobody cared about any of that. Nobody asked me any questions. And honestly, I was just a busy mom and a busy doctor. I wasn't even thinking about that. So it was really my suffering that made me think that I needed to help other women. But at the same time, I still wasn't addressing all of those very vital things. So they were curing my breast cancer. I hope it never comes back. But they weren't doing anything for any other aspect of my health. And in fact, my health was declining. It was.
Yeah.
Lipids were going up. I got bone loss. I mean, you name it, right? But then, and this is a very important point, is I get a phone call from a cousin who did not have breast cancer. She had an astute primary care doctor who said, hey, you should get genetic testing. You've got a strong family history. And we hadn't really been in touch. And so she'd gotten tested, and lo and behold, she carries the BRCA2 gene, and she calls me up. I know we haven't spoken in a while, but I carried this gene. Do you have it? I was like, wait, I have breast cancer and I don't have the gene, but you do. So I finally went back to my oncologist. I said, it was around 2013. I was like, listen, you need to retest me. There's something called update panel testing. And it's like, oh, you probably don't need it, Korea. I'm like, are you kidding me? And this is at a major New York City cancer center, one of the most famous in the world. Okay. And nobody from that cancer center ever recalled me and says, hey, you were tested in, 2001. You should have update tested. It was only because of this cousin called me. And lo and behold, I carried the BRCA2 gene mutation. Okay. And if it wasn't for me speaking up, I wouldn't know. My daughter needs to be tested. My brother carries the gene. My aunt carries the gene. We've got other family members who have now made surgical decisions to prevent. So that is a modifiable risk factor. And only 1 in 4 women in the general population, 1 in 4 women in the general population are eligible for BRCA2 testing, but they don't get it, or genetic testing in general, and they don't get it. And I see a lot of breast cancer survivors who say they had negative genetics, but it was a number of years ago, and they have to remember to do update testing. So, So back when I put myself in premature menopause surgically, I was was telling me, you're BRCA2 and you ovaries out, right?
Oh my, you've got to stop. I've got to unpick. My mind is just, I didn't know any of this, but what's so interesting for me is that you're this medical doctor, a scientist, a clinician, and you've just talked to me about 2 or 3 examples of when you did not make a decision based on evidence and facts. And I think that is really beautiful about your journey, because we are these 3-dimensional human beings, and we don't base all of our decisions on evidence and facts and science alone. And a lot of our decision-making process is really sort of indicated of what's happened in our past. Like your friend's passing, that tragic death as a very young mother has made an impact on you and made you decide perhaps a different way if that hadn't had happened. Your mother having ovarian cancer, all of those things really impact us today and our future self. And the same is with stories. Who are you following on social media? What sort of outlets are you tuning into? This will all become part of our consciousness, subconsciousness, and it will make us decide certain ways.
Yes. And our doctors make us decide certain ways. So my mission is, yes, there's tons of experiences out there, and you can be influenced by lots of things. But in the end, we do want to focus on science and we do want to focus on evidence. And what I am most dismayed about is now here I am, almost 23-year survivor, okay? And I've seen the evolution of where breast cancer treatment has been and where it's going. And we're going in a wonderful direction in that we're catching it earlier, we're having higher cure rates, we've got more tailored treatments, more personalized, more precision treatments. Yet, despite all of that, I still see a huge amount of, and there's an acceptable level of suffering in the medical community for women who are breast cancer survivors. I feel like we're in an arms race right now of like, how much can we starve these women of their hormones and suppress them in the name of this kind of, I don't know, it's a very purist view of treating their cancer and only focusing on this hormone suppression, right? And then so we have an army of women who are being left to survive, but to survive, with a lot of collateral damage. And no one's really talking about that collateral damage.
And we need to include women with other cancers as well, because I know our conversation is about your journey with breast cancer, but I speak to so many women after ovarian cancers, womb cancers, other gynae cancers who have also been pushed into the surgically onset menopause. And I have spoken to them when their life has fallen apart and they could not get out of their chair and care for their children. It is horrendous of what happens.
It's any cancer that affects your ovarian function or your sexual function, and not just ovarian function. It's women who have pelvic radiation. It's colon cancer survivor. It's yes, you're right.
It's huge.
It is huge. And so while we work towards a world where we're curing many more cancers, and but we're also diagnosing them at younger stages and younger ages, and we're getting them early, and so our survivorship pool is just rapidly growing. So who is addressing the elephant in the room of what to do?
I know.
Survivors. We're putting them at a much higher risk right now of heart disease, osteoporotic fractures, and dementia. Those three big ones are huge quality of life issues and honestly life and death issues for any woman, right? Those three things. Number one killer is heart disease. We know the severe risks of, osteoporosis and fractures, and the dementia risk, right? And so what are we doing? So are we going to just make all of these women either surgically or chemically menopausal and tell them to just be happy that they're alive and that their breast cancer hasn't come back and then ignore everything else? It's unethical, I think.
So you are in surgically onset menopause. Let's come back to your story. You're not doing great, but you're a busy mum, and you're working hard. And how did you manage your symptoms?
So finally, a nurse in my oncologist's office was like, Corinne, why don't you go into Celexa, antidepressant, right? Like it might help you with your sleep and hot flash. So I was like, well, someone is actually caring about me and thinking about me. So I did that. And yes, we know in about 50% of women, one of the antidepressants may help with certainly some of the anxious feelings, the low-grade mood changes. It helped a bit with the hot flashes and the night sweats. It helped me sleep somewhat. But it wasn't great, In retrospect, everything I've learned now, really doing menopause as a specialty, I would have done a whole lot different, right? I would have focused on my nutrition, on strength training, my exercise. I would have explored non-hormonal options to treat my hot flashes, my vasomotor symptoms. I would have been super proactive with vaginal hormones. And then as soon as I finished my tamoxifen and was done with it, I would have really advocated and educated myself about, my options for hormone therapy. So I'm kind of making up for lost time by helping other women because I kind of suffered for 23 years and I didn't do really any of those things because I was just juggling the things in my life. And I know it's a very big burden to put on cancer survivors being like, well, you want to feel better with all your treatments? Now we're going to ask you to do 5 extra things. But the reality is they're all things that everybody should be doing in life. And so you can think of yourself as having just an extra special reason to really push yourself to think holistically about your health.
Yeah, and sometimes we learn what you teach now is what you wish someone would have taught you, right? And that's okay. I think what you've just mentioned is so empowering, isn't it? It's that holistic approach, and that is our menopause toolkit for anyone who survived cancer. It's your exercise, it's your diet, it's looking at all of the non-hormonal treatment options. It's also looking at all your vagina, your vulval health, and looking also at our emotional health, like whether antidepressants work or whether you start a little bit of counseling or cognitive behavior therapy or look at complementary therapies. I feel like so many of us work so hard to put that toolkit together. It can feel exhausting, but when you've found a few things that work, it's really empowering because it's great for all of you, long-term health for now. But we have to work hard, right? You have to be dedicated to do this. It doesn't come easy. I love that you are here. It means so much to me and my whole team behind this show. We release this show for free to help people like you learn more about this often misunderstood topic. And because so many of us feel totally under-supported going through all of this. In return, all I ask is that you help me on my mission by hitting the subscribe button and clicking the button to turn on notifications. It really helps a lot. Thank you. And now on with the show.
And so to me, I find it highly unacceptable that when you've got a woman who is being told, we're going to put you into chemical or surgical menopause, we're going to give you medications that, listen, I know I mentioned that tamoxifen, I did well with it. And in premenopausal women, they often tolerate it better. But there's many women who really suffer with the side effects of tamoxifen. And we didn't even touch the women who have ovarian suppression and an aromatase inhibitor, which takes your estrogen levels and makes it even lower than kind of the classic menopausal level. So if you are meeting with a patient and you are saying, we're going to offer you this treatment, you better do two things. You better explain to her what the side effects are. The other day, I had a patient who was like, I didn't realize until I told my oncologist that I had severe pelvic pain with sex that I could have vaginal estrogen. He never asked me if I had vaginal pain or, vaginal dryness and pain with sex. And I never realized it was a side effect of my hormone, my adjuvant endocrine treatment. And once I brought it up, he was like, oh yeah, you can have vaginal estrogen. She's like, but meanwhile, I've been suffering for 3 years. And so to me, that's unacceptable, right? Like it needs to be up in the beginning. The other thing that I am seeing is that women don't understand the benefit of their adjuvant endocrine treatment. And many of these women either are suffering with the side effects and want to quit it, and they don't actually realize what the actual benefit. The other thing I see is women who are suffering from the side effects and want to stay on it, and they don't realize that their benefit is so small. Someone needs to say, this is your true benefit of doing this significant adjuvant endocrine therapy. And in some cases, the benefit's like 1% at 15 years. Now, that's your choice to make that decision. And I'm not saying that's right or wrong. But if you have a very small incremental benefit of continued adjuvant endocrine therapy, particularly on ovarian suppression and aromatase inhibitor, you better be told so you can make an informed decision. I'm seeing so many patients with early stage breast cancer, stage 1, low grade, grade 1 or grade 2, lymph node negative, who are on extreme endocrine therapy, meaning hormone suppression plus an aromatase inhibitors, and they think they have to stay that in 10 years, and they are suffering. And there are tools. There's a tool that your patients and your listeners know. Yes. Onco Assist, Adjuvant Online. Anybody, any health professional can use this tool. You can type in your type of breast cancer. This is for estrogen receptor positive breast cancer. And it will tell you what is your 5-year, 10-year, 15-year survival prognosis, risk of recurrence. And it will also tell you if you add in endocrine therapy for 5 years, and then you can do it again for 10 years. And when I show that to women, sometimes women have a big benefit and they're like, oh, okay, I get it, Dr. Menn. Let's work together to figure out how I can best stay on my medication. Other times I show it to women, they're like, wait, I have got a 1% benefit at 15 years. I'm like, no one told you that?
And the tool that you just mentioned is obviously the tool that you use in America. We've just had an oncologist doing a workshop with us, and she showed us the tool, how it worked. She did a screen share, and it was really great. She brought up two different patient examples of similar patients. Both were 47 years old, and a little bit she tweaked the figures, and the benefit was really different. And it was amazing to see on the data, on the chart. It really quite mind blowing.
That's informed consent. That's shared decision making. When you fully realize the benefit, of your therapy. And, so I think that's not being done. I don't see that being done, but with most, they're literally here, next step, here's your aromatase inhibitor. Next step, here's your tamoxifen, or next step, here's this. And okay, see you in 6 months. Like, that's it. There's no discussion.
So you kind of got by for about 20 years, which then how old are you now? And when did you think getting by is not enough?
Yeah.
What happened?
So I got by. So I Celexa, then I changed to Effexor, and we have a lot of data on Effexor, Finland vaccine helping, the hot flashes and stuff. So that helped me enough. I think I used vaginal estrogen off and on. I was just like my patients. Ooh, I was not compliant. Again, I think I was being a bad patient. I was too busy taking care of my family and my medical practice to really focus on myself. But finally, right before I turned 50, I read the book Estrogen Matters. So cheers to Avram Blooming. That book changed my life, and reading the scientific literature surrounding estrogen, hormone therapy after breast cancer. And luckily, I actually have a wonderful oncologist who really does allow a discussion. And so started talking with him, and I says, listen, I am only 50 and I've got my whole life ahead of me, and I feel like an old woman. I get out of bed, my joints hurt. I've got, I did the in-body scan. I had lots of visceral fat. My cholesterol was high. My thyroid was bad. My skin was terrible. When you lose vaginal estrogen and the hormones there for a long period of time, you start to normalize what you think your sexual life should be. And I was like, oh, it's okay. Use a lubricant. It's okay. Until I finally committed and made that next step to say, I'm going to be consistent. I know I can use vaginal hormones. That is always been, we know that that's very safe. And then I took the next step, and I says, I'm going to try for 3 months a transdermal low-dose estradiol patch. Started with the lowest dose, 1.025, and then 100 milligrams of progesterone in the evening. And then I went up to 200 milligrams. And I will tell you, within like 2 weeks, it was like a light bulb went off in my head, in my body, and I felt completely different. And to the point where I almost, even right now, I can feel a little emotional about it, because I was like, oh my God, like I was a shell of myself, and I was so young. I was only, 28 when that happened. And
yeah,
and I just think of all the suffering of women who had to live with that. And I feel really good now, and I'm able to sleep. My mood is better. My sexual life is better. I'm able to exercise. My all the good things we tell survivors to do. It was kind of hard for me to do because I wasn't sleeping. My joints hurt, and I had hot flashes all the time. So as much as, so for me, it's been a powerful decision. And I do it knowing that I don't have a perfect randomized controlled study that tells me I have guaranteed safety, that my breast cancer will never come back because of my hormone therapy. But what I do have is over 25 scientific studies that show there is no increased risk of recurrence. It does not worsen prognosis women who choose to take hormone therapy after completing their breast cancer treatment. So when an oncologist says it's unsafe, there's no data, it's actually just simply not true that there's no data. There's not perfect data. There isn't. And we're never going to have perfect data on this. But we have a whole world of a large body of scientific evidence that is somewhat imperfect, but, a growing body of information that says it's something reasonable to consider. I tell patients we have to make what seems like perfect decisions with very imperfect information. So what
Yeah.
can we do? We can take the best information out there, and we can, that's why we went to medical school, right? We were supposed to be able to process lots of information. We take that information and present it to ourselves and to our patients and say, this is what we know. This is what we don't know. How are you feeling? What would you like to do? And so that's kind of what I did for myself. I had tried the non-hormonal things. They helped for some aspects, and that's fine. But they weren't helping everything. And I just decided at this point, this is what I wanted to do.
And Corinne, I could see you getting emotional there, because I think sometimes when we look back, we only realize how rubbish we felt when we start to feel better. And there's also a sadness and a loss that comes with it, because you've spent a lot of your time here on this earth actually feeling with a very much reduced quality of life. And then we do feel a bit sorry and sad for ourselves, isn't it? For that younger self who's really struggled, who hasn't had better options, who just lived like that. But I think when it comes down, and I want to touch on 2 points, because you share beautiful from your personal experiences. Some women choose to stay on endocrine treatment, even if it just gives them that 1%, because what all of us doing, what you are doing, what I'm doing, what everyone at home is doing, we're all managing our risks, and we just want to stay alive, right? That is the main priority for most of us. And I don't want to speak for everyone at home, but I'm assuming, this is what we're doing. This is why we're going on these treatments. And at the same time, sometimes we wake up some days and we're like, I just need to feel a bit better than this. And what can I do? And it's a brave decision you've taken. Can I just ask you, in the UK, hormone replacement therapy for women who've had breast cancer, especially with hormone receptor positive cancers, see, I've learned my language, is contraindicated. You're a member of the American Menopause Society, is that right?
It's called the Menopause Society. It used to be called the North American Menopause Society. Yes, was it breast cancer? The language is breast cancer. A personal history of breast cancer is a relative contraindication to hormone therapy. But
okay,
and so that's an official standpoint in a very general term. But all of the contraindications that are mentioned in the Menopause Society statement, American College of OB/GYN statement, so like a personal history of cardiac event, heart attack, a pulmonary embolus, active liver disease, unexplained vaginal bleeding, and a personal history of breast cancer. Really, in all of those scenarios, you could go through each one of those and say, okay, in an individual patient with any one of those things, when you kind of dig deep and look at like the full picture, we don't treat patients by just like check boxes in an algorithm. We would look at them individually. And because breast cancer is such a, there's so many flavors of breast cancer, and there's women who are in active treatment, women who are long-term survivors. We can't just lump them all in one category. And there's a lot of like actual crazy upside down science that is happening, or not even science, cure is happening. And I myself is a perfect example. Let's go back. If I chose not to get my ovaries out, remember, at that point in time, I was getting close. I was maybe on year 7 of Tamoxifen. I had ovarian function. My ovaries were working. My oncologist was perfectly happy with me getting my period every month and having high levels of estrogen. I was almost about to complete Tamoxifen, a couple more years. And at that point, I would have been whatever, in my mid-30s, right? Nobody was telling me to remove my ovaries. So let's pretend I didn't have the BRCA mutation. Fine. I would have had normal ovarian function until the age of at least 51, probably, right? And no one would have had a problem with that.
Yeah.
Nobody. But suddenly, I chose to get my ovaries taken out. And yes, I know it was a little backwards because I didn't have the gene, but then I had the gene. But whatever, take my ovaries out. And suddenly, I can't have any estrogen? Like, how does that make any sense? It doesn't make sense. And I see it with receptor negative breast cancer patients all the time. These women finish their treatment. Sometimes their periods come back. If they're young women and they lost their periods, they come back. Nobody out there is telling them to have ovarian suppression because they're estrogen receptor negative. So they go 7 years, say, with their periods. Then they go through menopause and they're really suffering. And suddenly people are like, you can't have any estrogen. I'm like, are you kidding?
Yeah.
She had breast cancer. She was treated. She's had high estrogen levels for years. She's suffering now, and you're afraid to give her a teardrop when she had years of an ocean of estrogen. It literally doesn't make any sense. So these triple negative patients shouldn't be lumped in just with everybody. It needs to be much more nuanced.
Yeah. Tell me, I really want to understand how you made that decision. You spoke to your oncologist. What was your conversation like with your husband, for example? Tell me, how does that happen?
Well, listen, my husband, he's not in medicine. So he just trusts what I do. Like, he's like, okay. He's like, you sure it's okay? I'm like, yeah. Like, he defers to me because I'm an OBGYN. I think I'm in a unique, situation. I mean, I called in my own hormone therapy. I said to my oncologist, hey, Middleman, this is what I'm doing. He's like, okay, Corinne. I'm like, you need me to call it? I'm like, no, I got this. I mean, I'm privileged. I'm a doctor. I'm an OBGYN. This is what I do. For me personally, everything in life is risks versus benefits. There's a risk to doing something and there's a benefit to doing it. There was a risk for me not to do hormone therapy, for me personally. The risk is that I continued to suffer, not feel well, and in multiple facets of my life. And I was getting to be, at this point, as 23-year survivor, very concerned about the other I was getting more and more concerned about my heart, my brain, and my bones at this point. And I was like, if my breast cancer comes back, I truly believe that if it comes back, it was going to come back. I will tackle it and I will deal with it at that point in time. And I, will, do what I need to do. But I felt that for me, the benefits are far outweighing any risks. And I feel really good with my decision. And when I counsel other women, I think it's always important for anybody listening that I don't think that anything is black and white. Like, yes, you should be on hormone therapy. No, you should be not, whether you're a breast cancer survivor or just an average woman. But you deserve to have the information. And so my approach is normally finding out, where are you in treatment? Have you finished your therapy? If you're in treatment and you're suffering with menopausal symptoms, what can we do so that you can stay on your therapy? Is your therapy the correct therapy for you? Have you been fully informed? If so, great. If not, let's get informed. We're lucky to have lots of these non-hormonal treatment options now. I want women to be much more proactive. I feel like when they go to their doctor, they should be, here's your prescription for your aromatase inhibitor. Here's low-dose vaginal estrogen. We're going to prevent the horrific changes that are to come. Instead, they say, go away, use a lube and a moisturizer, come back in 6 months when it's not working, which it never totally works. So of course they're going to need it, but now they've got worse tissue, right? So we should be more proactive with the people in treatment. And then post-treatment, we need to, okay, let's come in for the oncology visit. Let's check on how you're doing in terms of your breast cancer, do your exams, any lab tests. But the second piece is, what are we doing to keep you healthy and alive besides your breast cancer? We are treating breast cancer and curing women in other ways. And so, that's the conversation. It has to be very individualized.
That third decision, that other big decision of going on a low-dose hormone replacement therapy, was that, do you think, an emotional decision? Like, we spoke about different ways of making decisions, or do you think that was more a scientific, data-driven, or a combination of? What was that?
I mean, it was data-driven. I felt comfortable enough with the data. I felt like I understood it, and I understood risks, benefits there from a very scientific standpoint. But it was also an emotional decision in that I was kind of just like, yes, I'm done. I'm sick of suffering. I want to commit to, a lot of women, listen, when they turn 50, like a lot of women who are going through menopause naturally, 50 is a wake-up call for them. It's a time to pause and think about themselves. They've been caring for all maybe their spouses, their partners, their children, their work for all these years. And now they're like, oh, I better like think about what I want for the next 50 years, right? So for me turning 50, it was emotional to me because I was like, damn, I made it to 50. I didn't think I'd even be alive, right? Literally, back at 28, I never thought I'd be here at 50. I thought I would definitely die of breast cancer sooner. I really never thought I'd be. And so now I'm like, damn, I got here. I'm like, God, do I want to be like this? Is this what I want for the rest of my life? I was like, no. So I felt very empowered and very, I felt like I was reclaiming a little bit more of, and being a little bit more in control of how I age. And I'm controlling how I'm aging with breast cancer. Because I still consider that I am still with breast cancer. Because once you have breast cancer, particularly estrogen receptor positive breast cancer, we know estrogen receptor positive breast cancer can come back at a much later stage, years later, right? Suzanne Summers, she, sadly passed away. She was diagnosed right before I was. So her passing is very sad for me and all breast cancer, of course. But, we were diagnosed around the same time. And it shows that like her and Olivia Newton-John, their breast cancer came back many, many years later, right? So, I understand that, but I think it comes to a point where you just, for me, I felt emotionally empowered. Yes. So it was a mix.
And it goes back to being so grateful for having survived, right? We're so grateful for being here. And we know so many people are worse off, but also better off. There are so many women who never get diagnosed with cancer in the first place. And so there's always someone who's worse off and someone who's better off. And we're just trying to do our best. And I know this is a really emotive conversation, and it comes with a lot of judgment, and it comes with a lot of criticism whenever I speak to people who are on hormone replacement therapy after their breast cancer. It comes with a lot of criticism, trolling. There are people on social media that often say to me, they want to share their story with me, but they say, I'd never come onto the podcast and share it because imagine the backlash I would get. And so
it's absurd for us to say, like, someone who has survived any medical condition, I don't care whether it's cancer or something else, and then, they're trying to then put their lives back together and make the decisions that are best for them. Now, we are not talking, to be clear, we are not talking about things that are not based in science. What we are saying is that breast cancer survivors deserve a conversation of what the available evidence is. We have over 25 studies. We've got the literature from pregnancy. We've got lots of science that we know about how tamoxifen works. And, there's a lots of different areas to draw on this body of science and evidence. It is not unreasonable to say to a patient, to talk to a patient and doctor and say, let's sit down and look at this and decide what's next in your life journey as you are a survivor. That's not irresponsible. In fact, it's irresponsible to not have that conversation, because it is. So let me ask you this. Are we cutting off testicles of men, right? Seriously, to treat their cancers, testicular cancer, and not giving them testosterone replacement? No. The very first thing, when my dad went in for prostate cancer, when he's doing fine, the first freaking visit that I went to with him, because he brought me in, the very first thing they talked about was his sexual health.
Yeah.
To preserve it. And I was like, are you kidding me? I'm like, how is from women telling me that oncologists tell them, you should just be grateful you're alive. Really, sex? Why do you care? Hot flash? Give me a break. Get a fan. So in the New York Times article, women have been misled on menopause, which went viral around the world. Dr. Stefan Fabian has a beautiful quote in there that went also viral that about the level of, there's an acceptable level of suffering for women, right?
Yeah,
and I would say
for sure,
take that times 10 for anybody who had breast cancer. Okay, There's an acceptable level of suffering in breast cancer survivors that is not tolerated, one, in the male population, and it's just not really tolerated in any other avenue in medicine. But there's something
Yeah.
about breast cancer survivors that it's just like this kind of suffering, whether it's sexual suffering or, quality of life suffering, it's considered, it's okay
Yeah.
to do.
It's a trade-off.
It's
It's a
a,
trade-off for having survived cancer.
but I tell patients it's not an acceptable trade-off. And there are really good non-hormonal things should be done with local vaginal hormones. And there are systemic hormone options that you deserve to have access and knowledge to. Your body, your choice. To me, it's part of reproductive health rights. And it's just the continuum of reproductive health rights,
Mm. And I'm going to just give you one example to finish this beautiful conversation with you. And that is one of managing risks. So we were cycling to the theatre with a whole group of my girlfriends. And the theatre is only down the road. We cycle along the River Thames. It's beautiful where we are in Surrey, in the suburbs of London. I am. And there's a whole bunch of us. And one of my friends, Rebecca, and I hope she will listen to this one day, she'll say, Danny, what are you doing? You're cycling without a helmet. And I looked at her and I thought, it's funny, there's about 7 of us and some of us wore helmets and others didn't. And she said, you're so afraid to have an ice cream because you think the sugar is going to make your cancer come back. But here you are cycling without a helmet. And that to her made absolutely no sense.
Yes.
In her risk versus benefit sort of calculation, it was much more risque to cycle along to the theatre without a helmet on and, being hit by a car. In my risk versus benefit sort of calculation, I would never even think about the blooming helmet. All I could think of was all the food and the sugar might, all of the other things I worried about. And so it's so personal, isn't it? And I really, truly also believe that if someone is curious about what would that mean for them, what would any treatment mean for them post their particular kind of cancer, we really do deserve the answers because it is our life and only us get to live it every single day.
Yeah, absolutely. And I think for breast cancer survivors, and you touch on an important point of this idea of whether it's sugar or having some alcohol or what you eat, you might have exercise. There's a lot of guilt and there's a lot of fear around all of these things. And, patients ask me, well, do you have any wine? Do you eat sweet? I'm like, I think that, listen, you have to live a life of happy balance. And if your happy balance is that you are really, really diligent about how you eat and your nutrition, that's great. And I encourage it. I think that's really important. But I also think you have to also live your life and not be afraid. Because as a doctor, I can tell you, I've seen the most unhealthy people in the world never get cancer or get cancer, don't do anything to improve their life after cancer. They survive their cancer and they live, decades, right? And I see tons of super fit, active, healthy women doing all of the right things who get diagnosed with breast cancer. And some of them recur, and unfortunately, we lose some of them. And you know what? You have to not be, don't put too much of a burden of guilt and fear on yourselves. You do your best you can each single day to feel as healthy and as alive as possible. And, and that may look different for everybody, but we need to let go of a lot of the guilt and fear.
Yeah. You know what? That is one thing I'm still working towards, and I'm 10 years on from my triple negative cancer diagnosis, and that is to live a life with less fear. And I feel that fear is something that was so hard for me to shake in all those years. And a lot of my decisions were definitely based on, so when I made decisions, they were based on fear and driven by that horrible feeling of the what ifs. And now I come more and more into that space where I make decisions based on really enjoying life and being alive. And what does it mean to be alive today, with all of my symptoms or none of my symptoms. But I think letting go of that fear is a really important part for all of us. Corinne, you've been amazing today. Thank you so much. This is a really difficult topic that I know a lot of people will maybe disagree with you or agree with you, and they will disagree and agree with what I've said. And all we can do is share our stories and our experiences. And you've been amazing. Thank you.
Well, thank you. Please, just so everyone knows, nothing that I say here should mean that I'm advising this for you personally. And I give individual advice to all my patients, and not everyone should make my decision. It has to be individualized, but you deserve to get access to that individualized care.
Thank you. Wow, I wonder how you're feeling now. I know whenever we talk about the use of hormone replacement therapy for someone with a history of breast cancer or cancer, it's an emotive subject. It's full of controversy. People have different opinions. It is contraindicated for anyone with a hormone receptor positive cancer or breast cancer in the UK. And so I know this is a subject that isn't easy. Many of you would have listened to Corinne, you would have agreed or disagreed with her. But what really was really highlighted for me in this conversation, it wasn't really about whether Corinne decided to go on hormone replacement therapy many years after her breast cancer diagnosis or not. What really stood out for me in chatting to Corinne was how many big decisions we have to make as cancer patients, and they're never easy. Whatever you decide to do, it's a decision. And not doing something or being indecisive is a decision in its own. And so I want you to just take a moment and think back, how many huge decisions did you have to make? And to give yourself a big pat on the back for making all of those decisions. And I sometimes look back and I think, oh, with hindsight, I would do things very differently now. And I sometimes look back and think, wow, Danny, you were really brave making that decision. You know, the doctors told me about my risks of more breast cancers with my genetic mutation, but it was my decision to have the double mastectomy. My doctors told me about the risks of ovarian cancer, but it was my decision. But I know because so many women, or all of the women on my dad's side in our family, died of ovarian cancer so early, way before they even turned 55. It was an easier decision for me because my family planning was complete and I was so worried that I would get ovarian cancer too. And so that was totally an emotive decision. And I know it would be a very different decision if someone hasn't completed their family, for example, or if someone hasn't had so many ovarian cancer cases in their family. And so whatever happens around you, what happens in your friends' lives, in your family's lives, the people you follow on social media, the doctors, all of this information is going to muddle its way into your decision-making process. And we all have to make so many big decisions. You know, many women and people just have to make plain, easy decisions, what to wear, to have a cup of tea or a cup of coffee. But once you've had a cancer diagnosis, you have to make a lot of big decisions. And it really shone out for me that it's just one decision Corinne made in her experience since her cancer diagnosis, and she made many, many others, including how to put together her gorgeous family. That was really such a highlight for me. I didn't know that about her, and I thought it was beautiful in how she put together her family, given her risks and benefits, and making her decisions, different decisions at different times in her treatment. And so I think this whole conversation for me is really about decisions, it's about information, it's about choice, and it's having all of those conversations in a non-judgmental and supportive way so that we can all lift each other up, even if your decision is totally opposite to my decision. We're still here as survivors, trying to do our very best we can every single day. And I really hope that all of us can come to a place where we feel we've got a good quality of life and we've done lots and we had lots of support by lots of amazing doctors to have this good quality of life, because we've only got this one shot on this gorgeous planet. And when I look back, I often look back with sadness, because there were so many years in my life post my cancer diagnosis that I was just so scared, and a lot of my decisions were based on fear. And I look back now at this very fearful Danny, and I think, gosh, it was a waste of time. And I know people said to me, oh, don't worry, worrying is a waste of your time. Whatever you worry about might never happen. But that never went in, and I couldn't internalize it. And now looking back, I think it was a little bit of a wasted opportunity, because here I am today, so many years on, having survived. But many years came with a reduced quality of life. I guess it's about learning and it's about showing up every single day. And so thank you for showing up to this conversation. And I thank Corinne again for having this open conversation, not with just myself, but with all of us. And I hope, that this conversation has been as useful as it has been for me, but also as gorgeous to hear Corinne talking about all of her decision-making processes. And with that, I love you and leave you. And I see you next week on the podcast. And I hope everything is okay in your world at the moment.